so let's define that. Glomerular filtration rate is the volume of what? That leaves where? For what? Is it volume of plasma that leaves the blood and goes into the filtrate, into the tubular fluid, right? Per unit time. Okay. Anybody have a comment about why this is correct? Does it make sense that the maximum clearance for a substance would be equivalent to the GFR? No questions about this? So conceptually, we're talking about moving blood plasma into the tubule, right? And whatever ends up there, if all of it leaves the body as urine, right? Whatever substance is in that volume will have been cleared of that volume, right?
What's the difference between GFR and the filtered load?
Okay, what's the difference between the GFR and the filtered load? So the filtered load is the milligrams of a substance that is filtered per unit of time. Okay. So if we're talking glucose, right? 100 milligrams per deciliter of glucose is filtered per unit of time. Okay. In the case of glucose, it's all reabsorbed. Okay, so none of it leaves the body, and we've cleared 0 milliliters of plasma of glucose.
Why would this not be the urine production rate? Like, why would it not be equal to the urine production rate?
Urine production rate is how much urine we're producing over time. And the amount of urine that we're producing doesn't necessarily have to be equivalent to the amount of clearing plasma. Okay, so let's take, how do I say this without saying they're just two different things? So let's use glucose as an example of that, right? Urine production rate is the volume of urine that's produced over time, right? So in a day you make almost 2 liters, or not you in particular, some person makes 2 liters of urine per day, okay, 2 liters. How much, the GFR is 180 liters per day, very different values, right? So the GFR is how much is filtered and enters the tubules, okay? And it doesn't tell us anything about the, what's happening there, but the urine production rate is a very clear measurement of just volume that's produced in a day, okay? So if we make 2 liters of urine per day, we have to be asking a question about clearance of a particular substance from the blood. So they're not at all the same. Okay, so let's take a visual look at that nephron, and maybe this will help a little bit. You might remember we talked about this concept of it's cut off a little bit, but renal plasma flow. Remember that? So we've got maybe a liter of blood every minute, but plasma makes up almost 2/3 of it, 62.5%. Okay, so we've got a certain amount of plasma that's going through the glomeruli, and we said about 1/5 of that under normal circumstances comes out. Okay, so we're moving plasma, taking blood plasma and moving it into the nephron. And then over time, what's going to happen is most of that blood plasma comes out, is reabsorbed. Reabsorb most of the water. We excrete maybe a milliliter per minute. All right. Very small amount. Okay. So what goes in is 625. What comes out is almost 625. Okay. So the most that we could filter, the most that we could clear, most of that plasma that we could completely clear of a substance would be the amount that enters the tubule, right? And how much enters the tubule? The GFR. So the GFR represents that fluid that's really leaving the plasma, right? Leaving the plasma. The rest of this renal plasma flow is just passing through the vascular parts of the nephron. They're not actually in the tubule. Okay? So the GFR tells us what goes into the tubule. You have questions about that, or should we go on? Going slow on purpose. No. Okay. All right. So we can determine the GFR of a patient if we have a substance that follows these rules that we talked about, right? So if we have a substance that is filtered, right? Filtered out the glomerulus, but then we don't modify it any further, right? We're not taking any out of the filtrate, we're not adding anything to it through reabsorption or secretion. We have a substance that can be filtered with that 125 milliliters of plasma. We can come up with a really good estimate of our GFR. But why would we want to know that? Okay, if you're a clinician and you have a kidney patient, why do you care about their GFR? What can you determine by measuring? What if their GFR is 200? What would that tell you? Yeah. No, but if we're actually measuring just the GFR, not with regard to any reabsorption process or anything like that, if we have a way of measuring GFR, independent of how much of this or that is reabsorbed, what could that tell us? Yeah, that would be a great indication. If you had excessive GFR, it would be a great indication that your membrane, your filtration membrane is breaking down. Okay. Does that make sense? So the GFR we talked about is determined by the normal pressures, right, plus surface area permeability. Okay. So let's say we had a patient and we're able to measure the GFR to be much higher than usual, right? They don't have any blood pressure problems. We could use that to tell us something very important about the integrity of the filtration membrane. Yeah. So being able to know this value has a lot of utility in case of people with kidney pathologies. Because it's not easy to go in and take a look at your kidney. Not at that level anyway. Okay. So the way that we do this, or can do this, is we have a substance called inulin. And yes, it looks like insulin, but it's inulin. Exogenous carbohydrate, what do we mean that it's exogenous? You don't make it. It's not found in our body normally, right? So we can inject you with this, or let's say a patient, and it's something that our body doesn't break down in our bodies, right? So it's going to be working through the kidneys, and what happens to it is that it has these properties that we talked about. We filter it, right? No problem. Whatever concentration the inulin is in the blood, that same concentration will end up in the tubular fluid. Okay, and then because it's not reabsorbed or secreted, we don't have a transporter for it. It's going to work its way through the tubule and then be excreted. Okay. So for this substance, the clearance of this substance will tell us exactly what the GFR is. Okay. It's not reabsorbed, it's not secreted, so it's only telling us about that filtration function. Get it? So if we need to measure GFR, we can take advantage of this concept of clearance. Okay. All right. So here we got Gramps. I've left you some clues. That's not just scaled. Okay. Okay. So I want you to go about thinking about this from the standpoint of it's your job to do this, right? So that you actually have to understand what it is that you're measuring. Okay. So let's go through and see what it is we need to know here. What we need to do. I don't know how many steps there are. Step 1.
Inject.
Inject. You just couldn't wait.
I just.
What are we going to inject?
Inulin.
Yeah, let's inject the inulin.
So now you get up like a fur vein.
Okay, what else?
Somewhere. Have the patient pee.
What do you want to do with that bag of urine, by the way?
Fill it. Well, they would
Empty
fill
it.
it.
Let's empty it first. Yeah, we're gonna empty
Well,
it.
I assumed an empty it.
All right, we're gonna inject this gentleman with inulin.
That's fine.
All right, why would we do that? Because we want inulin inside here.
Get up
Inside
there.
the cell.
Or his
Then what do we
wife,
do?
or boyfriend, whoever. Sister, brother, someone, child.
Yeah.
You like wait for a little while and then
Yeah, we want to wait for a while. Okay.
and then you like take the volume of urine that he's produced in that time and like divide it based on just so you can get like his rate.
Yeah, we need to know the rate of urine production, so we need to wait some time, right? And we could wait an hour, let's say, which is not a long time, but let's say we waited an hour, okay? And we came up with some volume of urine, right? So we need to determine urine volume. That's the V dot, right? Urine volume. Actually, that's not the V dot, that's, the V dot is the rate, excuse me. Urine volume divided by time, right? So let's say, you know, there's a production of 100 milliliters in an hour, okay? As by example, okay? What else do we do?
Measure the.
Say what?
Measure the inulin concentration in the urine.
Yeah, we need to know at that time what the inulin concentration is in the blood, okay? Or in the urine, what'd you say?
I said in the urine.
Okay, the urine. Inulin concentration in urine. Okay. So if you're looking at what somebody wrote on the whiteboard over here, it's kind of nice. Did that. Right, we've got our rate of urine volume production, right, which is our number 3 here, the urine volume divided by time, right, how long we waited. We have the concentration of inulin in the urine, right? And then what else do we need?
Plasma.
Inulin concentration. Plasma, okay. Great. So if we do this, we can calculate the clearance rate of inulin, okay? So the clearance rate of inulin, if we put that into words, what do we mean when we say the clearance rate of inulin? The amount of inulin, or the amount of plasma, what do we say?
Cleared.
Excreted.
What does it mean to clear inulin? Yeah.
The amount of plasma per unit time that no longer has any.
Yeah, that's kind of hard to come up with, isn't it? You have to think about it. The amount of plasma that has been cleared of inulin per unit time. Okay? So the amount of plasma that we've completely gotten rid of all the inulin from that volume of plasma, okay, per unit time. Okay? And that will tell you how much of that plasma has entered the nephrons, or entered the tubule portion of the nephrons per unit time. Okay, that's the GFR. Okay, so we can use this chemical to tell us about GFR. Okay. And if we're making if we have a higher than normal GFR, that can tell us that we've got excessive filtration, right? And if that's not a problem of high blood pressure, we certainly have a problem with that filtration membrane. Anybody remember that the term we use for one of those pathologies where we've got a problem with our glomerulus? Yeah, glomerulonephritis, right? Hard to say, glomerulonephritis. This is sort of the most common thing that you will ever encounter if you've got a problem with GFR. Okay? GFR problems are usually due to glomerulonephritis. That is, the filtration membrane is inflamed and probably breaking down because you have too much filtration. Okay?
It's a breakdown of the filtration membrane. If you want to know what it is.
No.
I just want to spot.
Okay. So let's take this step further. What if we want to know let me put it this way. What value is the maximum renal clearance equivalent? Okay. So we talked about GFR as the amount that is leaving the blood plasma. Okay. What is the maximum clearance that any substance could have from the plasma? What is that equivalent to?
What do you think is the
Cool.
you got it right in the beginning.
Okay, so let me first address filtered load. Filtered load is measured in what kind of units? Anybody remember?
Milliliters
Isn't it
a
like-
minute?
Milligrams of
per
a substance
deciliter.
filtered out of the plasma. We are looking for a value that is equivalent to clearance, right? The clearance is not milligrams, right? What is it? Milliliters of plasma cleared of a substance, okay? So filtered load and clearance they are related, okay? But one thing I really encourage you to do is to make sure that you're thinking in terms of units here. What's actually being discussed, okay? I had this problem all the time when I learned about this stuff. So renal plasma flow had a lot of answers besides filtered load. What is the renal plasma flow in generic terms? It's the amount of what?
Plasma passing.
Volume of plasma going through the kidneys. Okay. So if we could clear all of that, right? Is there hypothetically any more plasma we could possibly clear? No, that's it. That's the ceiling. Okay, so if we pass 625 milliliters of plasma through our kidneys, the most per minute, the most we could possibly clear is 625 milliliters of plasma per minute. Does that make sense? No? Right. We put 625 in. Right. And what comes out the other side is nearly the same, 624, 625. Okay. So the 625 milliliters per minute is what's going through the kidney. That's the flow through the kidney. So the most plasma that we could possibly clear is that amount. Okay. That make sense? So in order to do that, we can clear some of that plasma by the process of filtration, right? Where we're taking substances that are, let me draw some dots, right? We got substances here in the blood. Some of that can go into the renal tubule, right? But about 4/5 is gonna remain behind, isn't it? So we only filter about 1/5 of that volume. Okay. So how do we get the rest of that to come out? We put it in through secretion. Okay, so if we take all of the substance out of the blood plasma, we have extracted 625 milliliters of plasma, or extracted that substance from 625 milliliters of plasma. Okay, so if we have a substance that has a filtered load of 50 milligrams per milliliter, okay, and what comes out is 0 in the venous blood, okay, and 50 comes out in the urine. We have cleared the substance completely from the plasma, right? So whatever that the rate of flow through the kidney is the amount of plasma that we can clear. Okay, so let's talk about doing that. We have another substance that is of help for us to do this. Okay, so it's called PAH. Don't worry about spelling it. I will not ask you to spell. I might ask you to spell PAH. Can you do it?
No.
Not a good day, right? What are the properties of this substance? As it goes through the kidney, what's going to happen to it? It's going to get secreted, right? We're going to move it from the blood plasma into the tubule, right? Probably also filtering it, right? So we're taking all of it, 100% of it, out of the blood plasma so that 100% of our renal plasma flow gets cleaned out, gets cleared of that substance. Okay? So why would we want to know about a patient's renal plasma flow? What would this tell us? It doesn't tell us necessarily about filtration efficiency, but what else does it tell us? There's no obstruction, right? We talked about renal arterial stenosis as one possibility, right? In other words, there's no vascular problem. There's no problem getting blood through the kidney, right? You can see how you could, if you have a person with some problems, you want to be able to rule things in or out, right? You've got the ability to make sure their blood supply is working properly, right? That we don't have narrowing of arteries, right? And make sure their filtration works through the use of inulin. Okay. All right. All right. So, a couple of values I want you to remember. All right. So, number one, we have the substance called inulin. We also have an endogenous, that is something that's naturally in us, called creatine. And it's not quite as good. It's a rougher estimate, but it works too. And it has a clearance. These are standard values. It has a standard clearance of 125 milliliters per minute, which is equivalent to the GFR. Okay. I put the exclamation marks in there because that's exciting. Are you with me? Exciting? Okay. PAH is a substance, also exogenous, something like inulin we'd have to inject you with. But its clearance is equivalent to the renal plasma flow. Okay, so these are important values to know. Understand why these substances, why they are useful in determining clearance. Okay, why they're useful in determining clearance for GFR or for renal plasma flow. And then glucose as an example of something we've talked about. What is the clearance of glucose? It's 0. Why?
Because we
Fully
absorb
reabsorbed.
It's fully reabsorbed, right? We filter it, but then we fully reabsorb it. Sodium we haven't talked about, but this is filtered, and then it's mostly reabsorbed. Okay, so we clear a very small amount of plasma of sodium. Okay, you don't need to know the exact number, but if you remember, it's about 1. All right, that'll give you a good sense, 1 milliliter. Okay, that'll give you a good sense of how much sodium we're getting cleared from our plasma. Okay, last topic, pH. This is pretty simple. You might remember kidney looks kind of like this. Right, so after it's passed through our nephron, it's going to lead through those collecting ducts to a minor calyx on the right there. You see that minor calyx? Minor calyx is part of, or has, here, let's see here. Here's a minor calyx, here's one, here's one, here's one, here's one. They join together into major calyces, major calyx, which is part of the renal pelvis. Okay? And then urine moves on down the ureter to the bladder. Simple enough, right? So in the bladder, I'm going to spend just a moment here talking about what this structure is all about. What do we do with the bladder? Why do we have one? Why do we have a bladder? What if you didn't have a bladder?
You would just.
You dribble all day long, yes. We make about 1 milliliter of urine per minute. Something like that. Okay. 2 liters a day, 1.8 liters per day, right? So we have a way of storing it until it's the right time. Okay. So what we're going to talk about real briefly is how does this work? We have a voluntary component and an involuntary component. And no surprise, this involves the autonomic nervous system. Okay? So we'll talk about that. Real briefly, let's talk about how urine gets to the bladder. There's a structure, 2 structures called ureters that have lots of smooth muscle. And here is that smooth muscle, it's this layer here. Right? Lots of smooth muscle, and it works by peristalsis. So like your GI tract, your intestines squeeze food along the path. We're moving urine downward towards the bladder. Okay. The bladder itself has this unique transitional epithelium. Okay? So the inside can be all bunched up like this on the left when there's very little volume. Or when it stretches out, it reveals there's actually just a small number of layers. So these are transitional epithelium cells. If somebody has a bladder infection, you'll see transitional epithelium in the urine. Okay. The smooth muscle here comes in, the smooth muscle here it has a special name. It's called the detrusor muscle. Okay. And the detrusor makes up most of the bladder. Okay. There's a little segment at the bottom that is called the internal urethral sphincter. And then outside of that, there's a different muscle called the external urethral sphincter. This is part of the floor of the pelvis. And what's unique about this muscle, this is skeletal muscle. This is the one you control. Okay, this is voluntary. Whereas what happens with the detrusor and the internal sphincter is involuntary. Okay, you don't control it. It controls you. Okay. All right. So this is the last slide I'll leave you with. During filling, we have what is referred to as sympathetic tone, okay, like we have on our blood vessels. What does sympathetic tone do to our blood vessels? There's a slight degree of constriction, right? Well, here, sympathetic tone is acting on beta 2 receptors. Do you remember what beta 2 does in a smooth muscle? Like your airways? Yeah, it relaxes. Okay. So under normal conditions, your bladder is told to relax. Just chill, right? Don't do anything. And it slowly fills up. Okay. There's also an alpha receptor. What do alpha receptors tell muscles to do? Constrict. Okay. And those are found at the internal sphincter. Okay. And there's also somatic tone, that is body wall musculature, like your external urethral sphincter. And what happens when we stimulate skeletal muscles? Contract. Okay. So under resting conditions, we have the bladder being told to relax, the internal sphincter told to constrict, and the external sphincter told to constrict. What does this do? Keeps the urine inside of you. Okay. And there is parasympathetic innervation that will tell your bladder to contract. Okay, but you can see it's inhibited here. Okay. So we are out of time, so you'll just have to hold it. We'll talk more about this.
Thank you.
Next time.
Talking about pee is my favorite thing.
I'll just probably cut it down later.
Relearn yourself.